Now we have Dr. Greeshma. She is Assistant Professor at RIO Trivandrum. She will be talking about traumatic cataract and hyphema.
Good morning to all. I thank KSOS for this opportunity. Coming to my topic of today, traumatic cataract and hyphema. So if we have a case scenario like this, what next? So that is the scope of our discussion today. Coming to traumatic cataract, it can be the result of any form of trauma, be it a blunt or penetrating injury, electric shock, lightning, infrared radiation, or ionizing radiation. These forms of trauma can lead to hydration and resultant concussion cataract. So a thorough systemic and ocular examination is mandatory, and in the lens we have to specifically look for the anterior lens capsule rupture, any Voshier's ring or wrinkling of the ALC. Cataract can be an early or a late onset rosette cataract, a total cataract, or progression of immature cataract. The position of the lens is important, as in we can have a subluxation, a dislocation, or a phacodonosis, and any intralenticular foreign body also should be noted. The point here is any intralenticular adhesions may mask a phacodonosis, and in all cases we better consider that ZD is present before we take in for a surgery. Coming to the management, traumatic cataract can be either primarily extracted or as a secondary procedure. Primary is done when there is a dense cataract, when there is associated capsular rupture, and when there is phacomorphic glaucoma. This procedure decreases the risk of glaucoma and amblyopia in future. A secondary procedure is better because the eye is quiet. We can get a better biometry, and if the biometry is not possible, we can either do a secondary IOL implantation or the calculation can be based on the fellow eye. In open globe injuries, we generally defer a primary IOL implantation even if the traumatic cataract is extracted because of the risk of endophthalmitis. Intraoperative procedure depend on the surgeon and the patient factors. We can plan any of these procedures. This is the only case when we actually do ICC in this era also, and pars plana lensectomy is done if the age of the child is less than 2 years. It is usually done under a general or a regional block, and here we have to use some agents cautiously. The intracameral lidocaine and riponablu can go in through the area of the zonular dialysis into the vitreous. Lidocaine can cause a retinal toxicity, and riponablu can stain the vitreous, thus impeding the visualization of posterior lens capsule. The incision and the rhexis should be ideally initiated from the zonular dialysis. Every time this may not be possible. And any time after the rhexis, we can implant capsular support devices. It may be a capsular tension ring, a modified capsular tension ring, capsular tension segment, or capsular retention hooks. So these are made up of PMMA. They either come as a preloaded system in which they can be injected into the equatorial area or inserted via a Kellman-McPherson forceps. In case of small zonular dialysis less than 4 clock hours, we can either manage with an intraocular lens in the back, or we can inject a capsular tension ring. And more than 4 clock hours, we can either suture a Sione's ring or a capsular tension segment. These are generally contraindicated when there is a can opener capsulotomy or posterior capsular tears. Coming to the standard FDA approved CTRs, so they are either Mosher ring or optic ring. These are flexible rings which can be compressed. So generally we inject the rings into the equatorial plane through the rhexis. The Sione's ring, we usually suture it via a non-absorbable suture. Generally a tensor or prolene is used, and the suture is secured beneath the partial thickness scleral flap. Hydrodissection also should be very meticulous, it should be minimal, and it should be preferably done in the direction of zonular dialysis. Our aim is to prevent the enlargement of dehiscence. Phaco settings are very important. It can be done in or out of the bag. The settings should be low vacuum, low aspiration flow rate, and low infusion bottle height. The anterior chamber fluctuations should be kept at minimum. At any point the surgeon feels, he should convert into more appropriate techniques. And the cortex aspiration should be tangential and never radial for the fear of increasing the zonular dehiscence. And automated anterior vitrectomy should be done to clear the anterior chamber of vitreous, and IOL implantation depends on the capsular support and the surgeon preference. So coming to the second topic of today, traumatic hyphema. It usually occurs in young males, can be a result of blunt injury or open globe injury, and the bleeding points are generally from the peripheral iris, sphincter, or the anterior ciliary body. The hyphema, we know it is graded like microscopic or a microhyphema. A layered hyphema we grade from 1 to 4. The higher the grade of the hyphema, the higher is the risk of secondary glaucoma. It can be a total hyphema wherein the whole anterior chamber is filled with bright red blood, or an 8-ball or a black ball hyphema. In this, the actually blood looks blackish because of the hypoxia and impaired aqueous circulation, and there is a high chance of pupillary block and a secondary angle closure glaucoma in such patients. In cases of trivial trauma, always rule out cause of spontaneous hyphema. We have to look the iris carefully for any iris lesions. We have to see for any intraocular tumors like retinoblastoma, an IOL rubbing against the iris causing the iris chafing, or any systemic disease causing coagulation. Coming to complications of hyphema, there could be a hypotony, there could be secondary glaucoma wherein there is a risk of optic neuropathy, there is rebleed because of clot lysis and retraction. The problem with rebleed is that there is high chance of refractory glaucoma, and gonioscopy we usually delay for the fear of rebleed. It is done after a period of 5 to 7 days. Coming to the corneal blood staining, a triad of hyphema, glaucoma, and endothelial damage. This leads to corneal blood staining. So what happens here is that hemoglobin from the breakdown of RBCs, they enter the posterior corneal stroma wherein they are broken down into hemosiderin. This gives it a yellowish appearance. It clears very slowly, and it clears from the periphery. That's why it takes even years, or it might be a permanent process. The problem here is in pediatric age group there can be amblyopia, and this looks like clear lens dislocation, and it should be very importantly distinguished from clear lens dislocation. The treatment, our aim is to decrease the rebleed and the treat inflammation and glaucoma. Our mainstay is topical corticosteroids, cycloplegics, and AGM. Antifibrinolytics are a little controversial because in the final visual outcome, they actually do not have any significant outcome. They do prevent rebleed, but they have multiple systemic side effects. Surgical intervention is planned at the first sign of corneal blood staining or persistent IOP elevations. As you all know, this is what we follow: more than 25 for 5 days, more than 35 for 7 days, more than 60 for 2 days. These are done to prevent any corneal blood staining, peripheral anterior synapse formation, and to prevent optic atrophy. Or any hyphema resolving to less than half within 8 days also should be surgically evacuated. Sickle cell anemia, of course, is uncommon in our country, but this should be also kept in mind. So if any such patient comes, they have an increased risk of CRAO and ischemic optic neuropathy, and early surgical evacuation is planned, and certain drugs like carbonic anhydrase inhibitors and hyperosmotics are avoided in such patients. So summary for today is all traumatic cataract expects ulnar dialysis even if there is no phacodonosis, and always keep these capsular support devices in such cases, and in trivial trauma look for causes of spontaneous hyphema. Never miss CBS or secondary glaucoma. This should actually cost us because it might lead to a permanent visual disability. Thank you. Now let me welcome Dr. Regina Mohan PT. She is a vitreoretina consultant in Chaitanya Eye Hospital, Trivandrum. She'll be talking to us regarding the posterior segment complications of ocular trauma. Over to Regina.
Okay, good morning everyone, and thank you KSOS. Now we will move on to posterior segment involvement in ocular trauma. So many of the time, the posterior segment examination is very difficult due to corneal injury, hyphema, cataract, and vitreous hemorrhage. But whenever there is a zone 2 or zone 3 injuries, you should be expecting more posterior segment complications. And when to suspect an occult rupture? When the vision is very poor with PL or no PL, when there is dense SCH with enough hypotony, restricted EOM, hyphema, shallow AC, and vitreous hemorrhage, an occult rupture to be suspected and explained to the patient. Scleral laceration, Dr. Reshmi has already told, an immediate primary wound repair has to be performed with adequate exposure but with a minimal traction. A stepwise closure should be done from the limbus going posteriorly. So whatever retina or the choroid which has prolapsed should be very carefully and softly reposited while suturing, and you can ask for a help of your assistant. And whatever vitreous which has come out should be cut with an automated cutter without a traction. And our aim should always be for a watertight closure so that it will help in your secondary surgeries. So when to do a B scan? So all the blunt trauma, when your posterior segment view is poor, we can ask for a B scan. But in lacerated cases, the B scan is usually deferred till the primary repair. So this is over the concern of mechanical compression, which can expulse the contents, increase risk of infection, and a lot of artifacts can happen with the ill-contoured eye globe. So B scan is usually done after primary repair. And for the preoperative imaging, CT is the ideal choice. So we will just see some few B scan findings. In this you can see the vitreous hemorrhage, then a very small tag from the RCS complex, which can be a tear or a break. Then PVD we can see retinal detachment, posterior dislocated lens. And sometimes we can see the rupture of the posterior capsule also if we see very carefully, serous or hemorrhagic choroidals. And posterior rupture we can see as a discontinuity of the RCS complex with a hypoechoic lesion around the lesion, and vitreous hemorrhagic echoes can be seen in the vitreous cavity also. And of course the intraocular foreign bodies which can be identified with the B scan. So IOFB should always be suspected when the history is suspicious, when it is a high velocity workplace injury. At this point we should have a very meticulous slit lamp examination, look for corneal scar, iris holes, any tract into the lens, cataract, and a thorough indirect should be done to see all the periphery, and special care to be taken to see the inferior periphery. Okay, vitreous tract and intraretinal hemorrhage may give you a clue regarding the site of impaction of the foreign body. And if the indirect examination is delayed, in cases of laceration and all, sometimes the foreign body can be missed due to capsule formation. So whenever there is a very good vision, no signs of endophthalmitis, and no significant structural damage, we can always watch an intraocular foreign body with a very careful examination every 2 to 3 months with a slit lamp indirect and ERG if possible. But if there is signs of endophthalmitis, always try for a primary removal of the intraocular foreign body, but if the view allows only, or else first do the primary repair, IOFB removal later. So when to suspect a post-traumatic endophthalmitis? The high-risk factors include a dirty wound with a delayed presentation, large wound with a tissue prolapse, old age, and a retained intraocular foreign body. In severe cases, the presentation is very easy and easy for diagnosis, like hypopaeon, severe lid edema, chemosis, congestion, and pain will always be out of proportion to the injury. But in subtle cases, the diagnosis can be very difficult, but we should carefully look for AC reaction, vitritis, retinitis, and periphlebitis. And if the inflammation is progressing even after your suturing, you should always suspect an endo. Serial B scans will also help you to see the increase in the vitreous echoes. And whenever there is any kind of suspicion, always go for a vitreous tap with a gram stain KOH and culture and treat accordingly. And early vitrectomy is indicated when there is severe vitritis with IOFB and RD. Now after this bloody complications, we will just move on to common complication. One is commotio retina, that we know is a posterior segment whitening, commonly seen. Actually it resolves very nicely after 3 to 4 weeks with a very good visual recovery, and the vision is impaired only if it is associated with a severe RPE damage with subfoveal hemorrhage or choroidal rupture. Macular holes can be immediate or late, but most of the time spontaneous recovery is reported in macular hole up to 6 months. So always plan a surgery after 6 months only. And the closure is, spontaneous closure is very common in young patients when the hole is small and there is a good fluid, when there is no fluid cuff around the macular hole. choroidal rupture, it basically happens due to the mechanical compression where the non-elastic inner choroid along with the RP and the Brooks breaks. Clinically, if you see, you will be seeing a subretinal hemorrhage. Sometimes you can see a bare choroid in between. But these cases, we need a very regular follow-up because they tend to develop the scars. And common sites for choroidal rupture are the macula and the peripapillary area. And carefully, we have to follow up this patient for the development of a CNVM, which should be treated accordingly. And when there is retinal rupture along with the choroid, it is called a retinitis claviteria. It is very known to produce fibrovascular proliferations. And identifying a retinal break is very important because 80 to 85% of the traumatic tears are known to develop RD. So serial indirect ophthalmoscopy has to be done. And the last, I will just show you one case. This is a 12-year-old boy. He came to our OPD with a blunt trauma while skating inside the room. So he presented with a lid laceration and no PL vision. And the CT MRI didn't show much positive findings, but B scan showed an hypoechoic area at the ONH site. So with the clinical finding, the B scan and the no PL, we made a diagnosis of optic nerve head avulsion. So making this diagnosis is very important because all other optic nerve pathologies know we do some kind of treatment. And this we can avoid unnecessary treatments even though the prognosis is very bad. So thank you all, but make sure you always do a very good indirect ophthalmoscopic examination, that too very serial with a long follow-up.